Next, we'll go to an individual who I would like to call a friend. After the number of times that I have asked her to come forward, to come to Berks County and talk to us about the issue of addiction, she has done that. I've asked her to talk about the issue of teen health. She has done that. And whom am I speaking of? Dr. Rachel Levine. Dr. Levine is the Physician General for the Commonwealth of Pennsylvania. She is Governor Wolf's appointee, one of his best, I happen to think. She is also a professor of pediatrics and psychiatry at the Penn State College of Medicine. She was previously vice chair for clinical affairs for the Department of Pediatrics and the chief of the Division of Adolescent Medicine and Eating Disorders at the Penn State Hershey Children's Hospital. She knows her stuff. Would you join me in welcoming Dr. Levine?
That was such a moving story. Thank you very much. It really is a story of hope and recovery, and really more eloquently says anything that I'm going to say. But I'll speak anyway. But it's such a fantastic story. Thank you very much, and thank you, Senator. That's a lovely introduction. So let's see if this works. Oh no, going the wrong way. Here we are. So the scope of this problem in terms of the opioid crisis is really staggering. And it has to do, as has been mentioned, with prescription pain relievers as well as heroin. The 2014 coroner's report indicated that 7 Pennsylvanians a day die of overdoses. And that was an underestimate in terms of how they calculate those statistics. And if you think about it, that's just a terrible problem. Unfortunately, 2015 will be worse than 2014. So we have lost more people. We haven't collated that data yet, but we have lost more people in 2015 than that. And to bring that home, the statistic that I find is very sobering and really impacts people is more people die in Pennsylvania and in the country of overdoses than die of car accidents. Unfortunately, we always want Pennsylvania to lead the nation, but unfortunately Pennsylvania leads the nation in drug overdose deaths among young men 12 to 25, where 30 deaths per 100,000 young adult males die, and we're 4th among young people, male and female, in the country. So this is a staggering problem in Pennsylvania. As Senator Schwenk said, this is rural, this is suburban, this is urban, this is all demographic groups, all cultural and ethnic groups. It affects every family and everyone. It touches everyone. To emphasize some of the points that we're making in terms of treatment and hope and recovery, and one that I always like to emphasize is a medication called Naloxone. Naloxone is a life-saving medication that reverses overdoses caused by an opioid drug, such as these prescription painkillers or heroin. Naloxone is safe, Naloxone is effective. And it doesn't cause someone to get high. It doesn't lead to an addiction. It's not addictive. All it does, it has one use, and one use only, and all it does is reverse an overdose. It comes in 2 forms. One is an auto-injector. It looks like an EpiPen. If you've ever seen an EpiPen, it basically talks you through it. And the other is actually a nasal spray. It doesn't even involve an injection. Even with both forms, there's no needles available, there's no way you can get stuck, there's no way you can harm yourself or anyone, and they're both very safe and very effective. The nasal spray actually has a new FDA formulation. The nasal spray costs $37.50. It comes in a kit of 2, and it saves someone's life who is dying of an overdose. Now, Act 139 from the legislature allowed for first responders, such as the Pennsylvania State Police, municipal police, firefighters, EMS, etc., to administer naloxone to someone in the field. And it also allowed for friends and family to administer naloxone to someone that they know, and they will have immunity from prosecution. So the reason that was important is that if you have two people who are using together, sometimes there was a reluctance for, if someone saw an overdose, for them to call 911 because they were worried they'd get arrested. But if they call 911 and the police or EMS comes, they're immune to prosecution. It allows friends and family to get a prescription for naloxone, to have at home or to have on them in case their friend or family member who has this type of addiction has an overdose. Now, to review the administration's response to this crisis, the first is to try to prevent people from getting addicted in the first place. And so the ways that we're doing this, since a lot of this has been generated, as has been noted, through prescription pain pills and then the road on to heroin, is we're trying to educate physicians and other medical professionals to prescribe less opioid pain pills. And so So the way we're doing this is through actually working with our medical schools and osteopathic medical schools to teach medical students and other health professionals about pain, how to treat pain, about the pharmacology, how opioids work and when they don't, and about addiction and the medical aspects of addiction and how to get people into treatment. So we're treating our new young physicians, medical students, etc. about that. We're also treating physicians and other medical professionals who are currently in practice. So we have continuing education. This has been in partnership with the Pennsylvania Medical Society, but it includes all specialties. This has been done with the nurse practitioners, with physician assistants, with pharmacists, with podiatrists, with dentists, all about opioids, about prescribing guidelines, about addictions, about how to refer, about naloxone. So there's continuing education credits that were for all of those medical professionals on this issue. We also have been working very closely with other departments, such as DDAP, the Department of Drug and Alcohol Programs, on prescribing guidelines. So prescribing guidelines about chronic non-cancer pain. So we're not talking about patients with cancer, but chronic non-cancer pain, about alternatives to opioids, to emergency department, so that if someone sprains their ankle or even breaks their ankle, they don't get a month of a long-acting opioid, and then another month, and then they're addicted. We're talking to dentists, prescribing guidelines for pharmacists. Our new guidelines are for obstetrics and gynecology. People were getting a month's worth of a long-acting opioid after a normal spontaneous delivery, vaginal delivery, a month's worth and then another month's worth. It's not necessary. And then geriatric guidelines. The geriatric elderly population is at particular risk of overdoses. So this isn't only young people. It's all ages. They can be children who get to the medicine cabinet, etc. So we're working on those prescribing guidelines. The next step is our prescription drug monitoring program. So this was another legislative initiative, and so we are working to get this up and running in 2016, where when a provider, a physician writes a prescription for an opioid, it'll go into a statewide database, and when the pharmacist dispenses it, that will also go into the database. So if individuals who are addicted are going from one doctor to another doctor to another doctor, that will be noted, and then we don't just send the person out the door, they'll be referred for treatment. That's called the warm handoff, the facilitated referral for treatment. Sometimes it has to be a firm warm handoff, as you were alluding to, is without, well, maybe you want to go to treatment. No, it's like you have to go to treatment. So the prescription drug monitoring program is quite a task, and is under the leadership of Secretary Murphy, the Secretary of Health, and that we hope to have that up and running in a year. And then finally, aspects of treatment. It's very obviously not just very important, critically important, life-saving importance to get people to treatment for this type of substance abuse disorder, for opioids and the prescription painkillers. Treatment does work. Treatment does work. You need to applaud for that. the disease of substance abuse disorder can get better. And I emphasize what Doug had talked about before, is that this is a disease, no different than any other medical condition. We have to eliminate the stigma associated with people with this condition, that somehow this is a moral failing. This is not a moral failing, this is a physical. Treatment is covered by medical assistance, and treatment is covered by most, if not all, insurance companies. Sometimes it's covered very well, sometimes a little less well, but there is coverage. You should discuss, if you're looking at a treatment facility, you should make sure the insurance is compatible. If it's not, that's going to be difficult. You should inquire about financial assistance. Many fantastic treatment programs, such as Karen, will offer financial assistance, and I believe you offer financial assistance to anyone in Berks County. Is that correct? So, I mean, that's a tremendous resource for the members of your county. Patients should learn, people and family and patients should learn about outcomes from the treatment facility that you're looking for. What is their outcome data? We're looking to have more and more outcome data about the effectiveness of treatment. Lengths of stay are important. There's no quick fix. And there's lots of options for treatment. Now, sometimes this becomes a controversy, and there are camps of different options. And I'm really a consensus builder, and I really try to come to the middle. So there are abstinence-based programs which are very effective, but we should not forget medication-assisted treatment. So just like among other medicines, other illnesses, we use medicines. We can use medicines to help with opioid substance use disorder. So those medicines include methadone. They might include a medicine called Suboxone or buprenorphine, say that 3 times, or another one called Vivitrol. And there are excellent medicines that are available. Different treatments are best for different families and different individuals, and so treatment needs to be individualized. But we need to get rid of the stigma associated with medication-assisted treatment. For many patients, that is their path to recovery and to getting better, and we need to acknowledge that, and we need to assist them. But it's also important to remember that it's medication-assisted treatment. Giving someone Suboxone and saying, have a really nice month, is not going to be effective. So if someone is getting one of these medicines, they have to have the treatment, the substance abuse counseling and therapy and wraparound services to make it effective. So all these different methods, and we need to individualize the right treatment for the right person and the right family. Now, in terms of distributing Naloxone, I have signed 2 standing order prescriptions. And this is unique to Act 139. I can't sign your standing order prescription for antibiotics. Sorry about that. So this is for Naloxone for first responders. So I did that in April, where I signed a prescription that the Pennsylvania State Police, municipal police departments, EMS, fire, can get Naloxone. And actually, Secretary Tennis of DDAP and I raised money for the Pennsylvania State Police and municipal police to get it free. So we gave them doses. We have also gotten some other supplies to be able to, and all work towards recovery. Thank you.